Well, I think that if we have to decide which have been the most important changes in the management of metastatic breast cancer over the last 2 years, my first comment is that it has been exciting years, because it's not that easy to have so many things that have changed over the last years. And I would select maybe 2 or 3. The first one is the introduction of antibody drug conjugates, not only in triple-negative breast cancer with sacituzumab govitecan, but also in HER2-positive MBC with trastuzumab deruxtecan or TDXD, and also the so-called HER2-low metastatic breast cancer patients, also with TDXD. And we have exciting new clinical trials which are upcoming. So antibody conjugates for sure. Second, I think that also we have data, beautiful data, last year with Virginia, showing that elacestrant in those patients who have ESR1 mutant tumors and were on treatment with CDK4 and 6 inhibitors for more than a year or so, the absolute improvement with elacestrant was amazing. And elacestrant is now approved by the MEA, by the FDA, and other agencies to treat these patients. So I think that elacestrant has become a new standard of care in a group of patients with this tumor type and these mutations. We also have a good data with alpelisib, with capivasertib. I think that capivasertib is not for now, but maybe next year will be also available. It's an AKT inhibitor. And last but not least, I think that we should not forget the data. We are learning more and more about the introduction of liquid biopsy of ctDNA in the management of patients with the PADA-1 trial. So I think that basically antibody conjugates for sure. I think that elacestrant is something that is also there, and we should not forget what's coming next, another PIK3CA inhibitor, pathway inhibitors, and also the liquid biopsy. I think that the very near future will be there as well. Well, I think that in the next decade, antibody conjugates will be something absolutely spectacular for all tumor types, for sure in breast cancer, and not only in metastatic setting, but also in the early breast cancer setting. So antibody drug conjugates will play a terrific role in breast cancer. Second, I think that the new biomarkers that are upcoming, how to optimize the treatment with PD-L1 inhibitors, with immune checkpoint inhibitors, with more biomarkers, or with better strategies, I think that this is something that in the very near future we will be able to deal with. And also combining strategies, antibody drug conjugates plus other compounds. Second, I think that the liquid biopsy, I think that it will play a significant role. I don't know if in the metastatic disease for sure, but also in the early breast cancer setting. And if I have to say something maybe provocative, is that I foresee a way to change the clinical trial designs and the way to approve drugs. I think that it is difficult to run trials with, I don't know, 2, 3, 4, 5, 8,000 patients. And we have to be more creative. I think that we have to start thinking about clinical trials based on designs, based on strategy. It's not only A versus B. It's if A works, let's add B only for those patients where A is not working. So I think that something like Fergain-like trials, this is something that will have a great impact in the future of drug approvals.